Dr. Dakalo, hi. I can see you in now. All right.
Hi, hello.
Hi, Dr. Dakalo.
You know the issue of living in the Bundus. The network where I was, it didn't work, and I was far away from my house. So I had to now drive from my colleague's house to my house now. So I just got in because I was too far to be in my house. Then I had to get into the colleague's house. And then, yeah, okay. Great stuff. So I came running, guys, so please forgive me. And thank you for staying on. Yes, Dr. Verenga, how have you been, sir?
I'm all right. All right. It's raining now in Zimbabwe, so
I miss you, man.
It's getting better. It's raining now, so it's a little bit cooler than before. So yeah, I guess it's getting better now. Yeah.
Okay, beautiful. Thank you so much. Let me thank the colleagues who have been joining us religiously every week. And I must tell you, in my ward, the students, the interns, and the registrars, they know. I always say, what did Dr. Verenga say this Friday? And if you didn't attend Dr. Verenga's lesson, you're in trouble. So you are part of our training in our university, Dr. Verenga, and we are so grateful for that. Dr. Verenga, today you're doing routine screening for aneuploidy. Go ahead, Dr. Verenga.
Thank you so much. Thank you for giving me the opportunity once again, and thank you everyone who has managed to join. I hope it's not becoming too hectic, but look, on my side, I do not mind, because FIFA medicine is what I do every day, and I could go on and on and on and on without stopping. So today, thank you again, once again, Ashley, the wonderful work you guys are doing at the Pelvic Floor Foundation there. And thank you again, the guys at FMF Zim, and the guys in the fetal medicine units who are supporting this work. We'll make sure we produce the image that I will share with you today. So yeah, so let's get on with it. Screening for aneuploidy is something that we decided that probably it's better we do it in detail, because when we just browse through during the basic courses, there were so many questions, especially from our trainees, the registrars, and probably from other specialists who wanted to understand a little bit more, because it is a little bit gray area in our region here, because it's not being routinely offered in most government settings. But I thought it is important that we cover it the way it should be covered. So it may be a little bit heavy as the course for some, but I want to assure you that I've tried to simplify the best I can to make it understood. So if we start with the Down syndrome story, in 1866, Langton Downs, John Langton Downs noted that the way these babies who were being born, but these babies had very funny faces, and they had a skin that looked like it was too big for their body. This is what Langton Downs noted. And he also noted that this baby had some mental handicap, some neurological and some mental handicap of some sort along the way. So that was in 1866. But it took a very long time for the world to realize that there was need to screen for Downs. But Langton Downs had already noted that there were these kind of babies who were being born. Because in countries like England, public health system, or all the health system, is publicly funded by the government. They noted that women were giving birth to babies with Down syndrome, and unfortunately for the Down syndrome people, they will never leave home, they will never probably become independent because of the physical and the mental handicap they have. As a result, they became more of a social, economic burden for the country of England. So they decided that it was better to start screening pregnant women to identify those who are likely to have babies with Down syndrome, and then offer them probably the option of a termination of pregnancy so that Down syndrome babies, if possible, they are not born. This was not forced on the people. Of course, it's an option that people would be given. Then in 1970s, they introduced the maternal age as a screening tool to say women who are above 35 years, they should all be offered a diagnostic test. A diagnostic test means putting a needle inside someone's belly and taking the fluid which surrounds the baby, or taking the placenta tissue, which is chorionic villus sampling, and sending to the laboratory to see whether Down syndrome is there or not. So this was the maternal age in the 1970s. But what disappointed in those 1970s is that still Down syndrome babies continue to be born in women who are below the age of 35. So this therefore means that the age of 35 on its own was going to exclude certain women with Down syndrome who were below the age of 35. So people moved on to do more research, and they came up with serum alpha-fetoprotein as one of the markers for Down syndrome. Again, this test was probably picking about 60 out of the 100 Down syndrome babies, and it was not good enough. So people continued to research, and the triple test came again in the 80s. The triple test was now doing more markers than just the serum alpha-fetoprotein. These are second trimester markers, by the way. These are second trimester markers. That means they were being done after 14 weeks of gestation. So the triple test, which would include human chorionic gonadotrophin, alpha-fetoprotein, and either inhibin A or unconjugated estriol to make it quadruple test. So this test continued to be offered, but again, the detection rate was less and less than what was expected, and Down syndrome babies continued to be missed. Then in the 90s, then came the nuchal translucency by Professor Kypros Nicolaides, who noted that babies with Down syndrome, they actually had increased fluid behind the baby's neck when you scan them between 11 to 14 weeks. But the challenge that was happening then is that women were not coming to present to their gynecologist before their 14 weeks. Most of them would come after 16 weeks. So this as a method was being challenged by the fact that women were not presenting early, which I believe in most of our regions we are today, we still have this challenge where women do not come early enough to be offered screening tests. So, so having discovered that, still the nuchal translucence on its own was picking about 65%, 65 babies out of 100, which is about 65%, and it was not good enough. So then came the combined test. I'll describe all this. Then came the combined test in the 2000s, where you would mix both the maternal age, the nuchal translucency, and first trimester biochemical markers, which I'll mention. This is called the combined test. And this test is still present even today. This is the test which is being done in most parts of the world as we speak. Then in the 2010s, then came the fetal cell-free DNA test, which is the test of our times, which is the most sensitive test with a very high detection rate, which probably in the future will become the test for doing Down syndrome screening. However, at the moment it's being limited by the cost, that very few women afford to have it, where the screening is not funded by the national health system. So Professor Kypros has done a lot of work in Down syndrome and probably has revolutionized the screening for Down syndrome. And most of the Down syndrome that is happening throughout the world is as a result of his amazing work in Down syndrome screening, as you will see during my presentation. Then if we were to just compare these methods which I've mentioned, these are the detection rates which I've already mentioned that, but before I go there, let me just emphasize a point here that actually you may find that, especially in our region down here, there are people who are still screening women based on maternal age alone. They will send a woman for Down syndrome because she's above 35 years. What it simply means is that you are still practicing in the 1970s. That means you are going to miss most of your patients who actually have babies Down syndrome because they are under the age of 35. Because more than 50% of Down syndrome babies are born by women who are below the age of 35. So if you are still stuck in the 1970s, you are not doing a lot of service to the women we are looking after, because Down syndrome babies are found also in women who are below the age of 35. Then because most of our women are not presenting early enough before 14 weeks, you may find that most practitioners may still be offering the triple and the quadruple tests, which are not the best tests to offer, but we need to change this because this is not good enough. Then there are some who are still just sending the woman for an NT scan. Just go and have your NT. If the NT is reported by the sonographer as normal, they tell the woman that we have screened you for Down syndrome. I want to tell you that this is in the 90s. We are still practicing in the 90s, and we all need to move with our times. We need to migrate and either offer the women combined tests or a fetal cell-free DNA test, because this is the practice of the 90s before more better methods were discovered. Then when it comes to the, to just show you, this is just a table to compare all these methods. You can see that the knockout test, if you just do the knockout translucent and you stop there, you don't do anything, you are more likely to miss between close to 40, between 30 and 40% of your babies with Down syndrome. If you use the maternal age and you do PAPA and beta CG in first trimester, this is first trimester, and this is first trimester as well, you are going to miss 40% of babies with Down syndrome, because the detection rate is about 60%. Then if you do the combined test, that means you miss about 15%, which is probably better than these two above. So this is the combined test, which is done probably in most countries in our region here. And in most parts of Europe and England is still doing this kind of a test for most of its pregnant women. Then if we do add additional markers as recommended by Fetal Medicine Foundation, I'll describe these markers in my presentation. That is the nasal bone, ductus venosa Doppler, and trachea regurgitation. We're going to improve the detection rate to 92%. That means we'll only miss 8% of babies with Down syndrome. If we do the triple test, which I said, unfortunately, most of the women in our region present in second trimester, that means we will miss about 30% of babies with Down syndrome, because the detection rate is just 69%. Then if we do the quadruple test, that is 81% with the quadruple test, we better say about 19%. Then if we offer the fetal cell-free DNA test, which is either called NIPT, sometimes it's called the Harmony, depending on the trading company, or triple screen, there are various names used for the fetal cell-free DNA test. We are only going to miss 8 out of 1,000 babies with Down syndrome. So this is the best test to offer. The only limitation is that is currently beyond the reach of many. So if we were to offer a test, we are saying these are the tests which are better to offer. We can offer them fetal cell-free DNA test or a combined test with additional markers. If we can't do this one, at least let's do this one, which gives us a detection rate of 85%. That is the combined test without additional markers. Then why were women coming after 16 weeks? It is because when England decided, England was always the leader in terms of antenatal care in those times. So England decided, after some protests from women's groups, that they wanted to offer their women antenatal care. But to manage the health system, the health minister of those days, Arthur Greenwood, promulgated that women should start presenting for antenatal care at 16 weeks without any rationale or any evidence to say why should they present at 16 weeks. So women started to come for the very first time to be seen at 16 weeks. This is why when the screening started, people started to screen women in second trimester, because there was no one who was coming before 16 weeks. And most of our regions or our countries were still stuck to this. Most of our women do not present to us until they are 16 weeks. But we are saying they are following a 1929 protocol, which has since been changed even by the very country which introduced it. So Professor Kypros Nicolaides, in the 90s and 2000, he started presenting on the turning of the pyramid of care, because he had discovered that it was possible to start screening for pregnancy complications as early as 12 weeks by doing an ultrasound scan and measuring the fluid behind the baby's neck. So what does this mean? That means instead of women coming for the very first time at 16 weeks, women should now come for their very first antenatal care at least minimum 12 weeks or even earlier, so that their pregnancy can be accurately dated and they come at the right time at the 12-week scan. So this was what Professor Aneuploidy he argued to say, look, it is possible that all women, instead of them coming at 16 weeks, they should come at 12 weeks so that they can be offered screening for Down syndrome. But now we are aware that it's not just Down syndrome that can be offered there. We can screen them for preeclampsia as well. We can screen them for preterm birth and all the other things at 12 weeks. As I'm speaking, most women in England now present at 12 weeks for the screening for Downs. So some may argue and say our women in our region will never present at 12 weeks. But I want you to be aware that it is a mindset, because even when Professor Aneuploidy started the idea of women coming at 12 weeks, people were arguing with him that no one will come at 12 weeks. But as we are speaking, most of the progressive world, women actually present at 12 weeks to have their pregnancy looked at, dated, and offered screening for aneuploidy. Then before we go deep into the Down syndrome screening, when women come at 12 weeks, it is not only the measuring of nuchal which is important, because I've seen that in most cases when women go to the sonographers or radiographers, all they do is to measure the CRL and then they go on to measure the nuchal translucency and the scan is complete. But I want us to be aware that it is beyond, we have to do the scan beyond just doing the nuchal translucency and the CRL. I'll explain why it is important to do that. So what is the scanning protocol? Of course, the scanning protocol, the most important thing after checking the viability and the number of features that are obtaining, we need to do a proper CRL. A proper CRL, that is crown rump length, which is measured with the baby in strict sagittal position, where we see the tip of the nose and also the genital tubercle scene, which is the feature gender. And the calipers for doing the CRL should be put on the rump and also on the crown, and we should make sure that the baby is horizontal and there is fluid between the chin and the chest. And if we were to draw a line here, the line should either be a straight line or should form an angle of about 15 to 30 degrees to make sure that we are not overflexing or we are not extended at the level of the neck. So this is how a CRL should be done. And for us to offer screening for aneuploidy in the first trimester, the crown rump length should measure between 45 and 84 millimeters to offer screening for aneuploidy in first trimester. Then in terms of the nuchal translucency, because the nuchal translucency is always compared to the CRL. This therefore means that you cannot do the nuchal translucency without doing the CRL. So the CRL should be done appropriately and properly. If you underestimate the CRL or overestimate it, it will affect the interpretation of the nuchal translucency. Then the nuchal translucency from the same image of the CRL, well, all we need is to apply some knobology on the image and we'll be left with the baby's thorax and just the baby's head and the thorax. Then we reduce the gain or the grayscale until the image is dark enough to remove the fuzziness that we sometimes see around the nuchal space. When the nuchal space is as clear as it is, and the amnion should always be visualized to make sure that you are not measuring the amnion. In this case, this fetus amnion is here because before 15 weeks, the amnion is not yet fused to the chorion. So we should see the amnion as we see there. Then when we measure, we should make sure that the caliper is seated on to on. You are not measuring within the thickness of the nuchal or the thickness of the baby's neck skin there. So it should be on to on and it should be perpendicular as demonstrated on that image there. And we should measure the thickest part of the nuchal. So we should make sure that our baby is strictly sagittal, seeing the tip of the nose, and we are not seeing the zygoma. The zygoma is this bone which comes out if you are oblique here. This is the maxilla and the mandible. So this is how we should see the baby's head, and also the thorax and the skin of the back of the fetus continuous like this. If there is a cord, an umbilical cord around, then you have to measure above and below the cord, then you calculate the average of the two. So this is how the nuchal translucence should be done for us to make sure that we have done it properly. These are the most important images when you are scanning the 11 to 13 week babies. Then we need to assess the nasal bone. To assess the nasal bone, on the same image we check the nuchal translucency, we just need to make sure that the beam of the ultrasound scan is perpendicular to the baby's nose. Then we lower the grayscale as we did here. You can see we've lowered the grayscale, we've made the image dark, we've adjusted the dynamic range on the machine, and where we are now, we can see that there is a nasal bone below the baby's skin. The tip of the nose is the baby's skin, and the skin above here again is the skin is on the nasal bone. The nasal bone is this white part, which is marked by a small 1 there. This is another baby where we could not outline the nasal bone. If you just look and say if the nasal bone is there or not, it may look like it's there, but if you compare these two images, you can see that we don't see the second line below the baby's skin. So this is a baby who had a hypoplastic nasal bone in first trimester, where the nasal bone was not identified in first trimester. It does not mean that the nasal bone will be absent in second trimester. Then the ductus venosa should also be measured properly. We've already probably discussed this, that whenever we are measuring the ductus venosas, we should try to elevate the baby's back to make sure that our angle is aligning to the vessel. The pulse wave gate is parallel to the vessel, and we measure the ductus venosas looking for the A wave. So this was a normal ductus venosa where the A wave was present. This is systolic wave, diastolic wave, and the A wave here. This is one of our images where the ductus venosa was actually reversed. So these are the secondary markers that we talk of: absent nasal bone, reversed ductus venosas, and this is the tricuspid regurgitation, whereby if you are doing tricuspid regurgitation, we want to put the baby's heart in the 4-chamber view. Then you go to the tricuspid valve. The tricuspid valve is the one on the right side of the heart. So we go on the tricuspid valve there. Then we put our pulse wave gate. We should be at 3 millimeters, the pulse wave gate. When you put the pulse wave gate, you should make sure that 1/3 of the pulse wave gate is in the atrium, while 2/3 is in the ventricle. Then we sample and we get a tracing like the one we see there. So in this case, we'll be saying this is a normal tricuspid pulse wave Doppler, because we do not see a negative waveform which represents the regurgitation. The next image will show you the regurgitation jet, where there is a negative flow here, which is more than 60 centimeters per second, showing that there is indeed tricuspid regurgitation at the level of the tricuspid valve on this baby here. So this is how we assess the secondary aneuploid markers. Then we go on to assess the anatomy. There is a certain anatomy which you should assess because it has got a significant meaning when it comes to the risk estimation. The orbits should be seen, as we can see that there are 2 orbits. This is how we rule out cyclopia. Cyclopia means that we'll just be having one eye, or hypotelorism. We see this condition in holoprosencephaly. Holoprosencephaly is a first trimester diagnosis. Aloba holoprosencephaly is a first trimester diagnosis, not a second or third trimester diagnosis. So this is why we need these kind of images, so that we don't miss a condition such as holoprosencephaly, which should always be diagnosed in first trimester. Then we check also the palate, and we also check the retronasal triangle here. The retronasal triangle, the palate, this is the alveolar ridge where the teeth will develop. That the palate, to check for big cleft palates in first trimester. The same applies to the retronasal triangle, where we see the maxilla and also the side bones there. That's the retro nasal triangle, which we also use to screen for big cleft palates. Small cleft palates will be difficult to detect in first trimester. Then when we go to the heart, we also want to check the heart to make sure that there is filling that is happening to the two ventricles. We can see the filling of the heart there. Then we should also check the situs by making sure that the stomach is to the left as well as the heart pointing to the left. After identifying the baby's left shoulder, that's how we come up with situs. Then we check what we call the three vessel trachea view, where we show that there is a pulmonary trunk continuing as the ductus arteriosus and being made together with the aortic arch and the isthmus here. This is how we assess the great vessels or the outflow tracts in first trimester by checking what we call the three vessel trachea view using color Doppler this way. This will allow us to rule out for major defects such as hypoplastic left heart, or to suspect defects such as transposition of great vessels or tetralogy of Fallot. Then we also need to check at the level of the bladder to make sure that there are two vessels which surround the fetal bladder like this, so that we rule out single umbilical artery, which signifies that there may be underlying chromosome abnormalities or other defects of the kidneys or the heart. So we do this image to demonstrate the three vessel cord. Then we also do this image where we measure the bladder. When the baby is in sagittal view, we measure the bladder's length because we want to screen for megacystis or a big bladder, which is also a marker for aneuploidy, chromosome abnormalities. Then we check the cord insertion. The importance of checking the cord insertion, we are confirming the intactness of the anterior abdominal wall. Anterior abdominal wall, such as exomphalos or omphalos, greatly changes the risk of a baby in terms of chromosome abnormality screening. So we need this image in first trimester, which shows these three lines where the umbilical cord is joining the baby on its tummy there. It's a very, very important image to demonstrate because we have ruled out one of the bed malformations such as exomphalos, or in very sad situations, body stalk anomalies or pentalogy of Cantrell. Then we go on to assess the posterior fossa of the baby. At the posterior fossa of the baby, we want to look, when the baby is in sagittal plane, the same image we use to check the nuchal translucency. After reducing the grayscale and making the image darker, we check at the back where we measure what you call the brain stem, because this is the part of the brain stem we see there, which continues into the spinal cord. So this is the brain stem component, and just below, behind it, we have the fourth ventricle and the cisterna magna space. This space, these lines, you say, the dark space, this is the cisterna magna, this is the fourth ventricle, and this is the brainstem here. So we measure this space, we call it the brainstem hospital bone ratio, where we measure and compare this ratio. Because this ratio is normally inverted or becomes greater than 1. If we divide this 2.2 divided by 4.48, it should never be more than 1, this ratio. If it is more than 1, then we'll be suspecting that there is likelihood that there is a major spinal myelomeningocele or a spina bifida, and the baby will need to be scanned through a transvaginal scan to look at the spine carefully to rule out major myelomeningocele. So that we call this, this is the posterior fossa. This space is what is called the intracranial translucency, the fourth ventricle there. Then we also want to measure the BPD or biparietal diameter at this level, where we see the choroid plexuses with the midline, which is the false cerebri. We get this image in first trimester. In second trimester, we will not get this kind of an image because the baby's brain is developed. So this image is showing us the choroid plexuses. These are the two choroid plexuses with the midline. This image is very important because this is the image that allows us to rule out holoprosencephaly and allobar holoprosencephaly and also anencephaly. Anencephaly and allobar holoprosencephaly are first trimester diagnoses, not second or third trimester diagnosis as is happening in our region. And of course, the spine also has to be checked. Then the kidneys have to be looked at. They are easier to see in coronal plane. As you can see, these are the baby's kidneys. I know they may be, you guys may find it difficult to appreciate them, but these are the kidneys with the renal pelvis which appear aneuploidy there. And we always check the blood flow to these kidneys to just confirm that they are indeed present, especially in difficult scans. Then the extremities have to be checked to make sure that all the extremities are there. You don't want to tell a woman with focomelia where there are absent limbs that your baby is normal, yet the baby does not have the limbs or the limbs. So you always have to confirm that the extremities are present. Now, having done that, the question now is, if you do your nuchal translucency and you find that the nuchal translucency is actually increased, as is seen in one of my images here. So if you find that the nuchal translucency is increased, this is the message that we always tell the women we find with the nuchal translucency which is above normal. We say the nuchal translucency is normal or abnormal when you compare it to the CRL, not to the woman's gestational age or the pregnancy gestational age. We compare the nuchal to the crown rump length of the baby. That is when you measure the baby from the head to the tip of the rump, then we compare that to the nuchal translucency, as I'll show you on the graphs. So a nuchal translucency is below the 95th centile. What it simply means is that the risk of chromosomal abnormalities is about 0.2%, which is okay because it will be probably below the population risk. So it will be about 0.2% because the population risk of having Down syndrome is about 1 in 500 or so. But so it will be below 0.2%, which is reassuring in normal nuchal translucency. So it does not necessarily rule out Down syndrome when it's want to say, but we are saying the likelihood becomes very little. And of course, these are the other risks. If the karyotype is normal, the risk of fetal deaths are these ones. But I want to come to the abnormal ones to say if the nuchal translucency is between 95 and 99 center, that is between that is between 95 and 99 center, which I'll show you in the nomogram. The risk of chromosome abnormality is about 4%, which is at 3.7% there. However, the risk that the chance that the baby will be born alive and well is about 93%. And the risk of major fetal defects is about 2.5%. What you have to note is that the trend or the likelihood of having, the probability of having a chromosome abnormalities increases as the nuchal translucency becomes more and more abnormal. For example, a nuchal translucency of greater than 6.5 millimeters will mean that the risk of chromosome abnormality is about 64%. And the risk that the baby will die in uterus is about 19%. And the risk that there will be a fetal defect is about 46%. And the risk and the chance that the baby will be born alive is about 15%. What message is this table telling us? What this message, what the table that this message is telling us is that if the nuchal translucency is abnormal, it is not just the chromosome abnormality that we have to worry about. We also have to worry about the presence of major fetal abnormalities. We have to worry about the risk of the baby dying inside the mother's womb. This is the reason why a woman with abnormal nuchal translucency will need to be referred to a fetal medicine unit so that the baby can be evaluated on top of chromosome abnormalities for these other conditions. So even if the baby's chromosomal defects screening is normal, let's say you have done the amniocentesis and the result comes back as low risk, that does not mean that the baby is okay. The baby will still need to be ruled out for major fetal abnormalities and also to be continuously be screened for the possible cause of intrauterine fetal death, such as placenta insufficiency, placenta insufficiency and fetal maternal hemorrhage. These are some of the leading causes of why babies die. So, having seen that graph, the question is, if an NT is done, you have sent the woman, you are the practitioner, we have sent the woman to have an NT scan done. If the NT is done, in most of our regions, most doctors don't do their NT. They are done by sonographers. They are done by radiographers. So if it is done, the NT, what is it that you have to do as the practitioner? If the NT is done, you have sent the woman for NT, the NT is normal, that means it's below the 95th centile, the woman will still need to be offered combined tests or a fetal cell-free DNA test, depending on whether the woman can afford the fetal cell-free DNA test to screen for aneuploidy. And normal nuchal translucency does not exclude Down syndrome and does not mean that you have screened the woman for Down syndrome. If the nuchal translucency is between the 95th and the 99th centile, the woman still needs to be offered combined tests or a cell-free DNA test, depending on whether she can afford or not. If the risk is low from the combined or a fetal cell-free DNA test, the nuchal fold will still need to be assessed at 16 weeks. If it is too persistent, this woman will need to be offered torch screen and a fetal echo at 20 weeks. Because the incidence of cardiac defects is increased in women with abnormal nuchal translucency. If the woman is high risk after the combined test or the fetal cell-free DNA test, then the woman will need to be offered amniocentesis, that is both the chromosome, the conventional karyotype and the chromosome array. That is the comparative genomic hybridization array, where we look at the chromosomes at a higher resolution. Then if the nuchal translucency is above the 99th centile, then the woman, in this case, it is worthy to just offer the woman a diagnostic test. I know that in clinical practice, some people may prefer to offer cell-free DNA tests first, but if the nuchal translucency, because of what you have said here, that a nuchal translucency above these values, these are the risks involved here. Because of those risks, it is always prudent to offer a straight diagnostic test at the CVS or amniocentesis and request both the conventional karyotype and also chromosome array. If the CVS or amniocentesis is normal, then the nuchal fold need to be reassessed at 16 weeks. If still present, we need to exclude other causes like torch. Then we need to do a torch screen. And then a fetal echo should be done again at 20 weeks to exclude cardiac defects. And we should be aware that these are some of the causes of why babies have increased nuchal translucency. It's not just Down syndrome alone. Cardiac dysfunction can cause it. Venous congestion in the head and neck can cause it. Then altered composition of the extracellular matrix can cause it. And also failure of the lymphatic drainage and fetal anemia and hyperproteinemia and fetal infection can cause it. So all these causes you need to be assessed on a baby who has an abnormal nuchal translucency, where you have done the screening for Down syndrome and the diagnostic test, and the test come back as normal. Then what about the major markers? We have sent the woman for screening for a scan, 11 to 14 week scan, and somehow you bump onto some of these major markers. What does this do to the risk? So irrespective of the measurement of the nuchal translucency, if the baby has a hollow prosencephaly, then the risk for trisomy 13 becomes 1 in 2, irrespective of the measurement of the nuchal translucency. The risk that this baby will have trisomy 13 is 1 in 2. If there is evidence of diaphragmatic hernia, then the risk of trisomy 18 becomes 1 in 4. Then if there is arterioventricular septal defect at the level of the heart, then the risk becomes 1 in 2. If there is exomphalos, then the risk of trisomy 13 becomes 1 in 4. The risk for trisomy 18, which is Edwards syndrome, becomes 1 in 4. The risk for Patau, which is trisomy 13, becomes 1 in 10. If there's megacystis, that is a big bladder, which we mentioned that you have to do, the risk becomes 1 in 10. This therefore means that checking for major defects is very, very important, because it alters the risk calculation for Down syndrome. Irrespective of your measurement of the nuchal, these become the risk. That means automatically the woman becomes a very high risk case that needs a diagnostic test, you may not have to proceed to do the combined or the fetal self-readiness test, but you might want to go straight for the diagnostic test, that is an amniocentesis or a CVS, depending on the gestational age. Right, so I've just touched the nuchal translucency because I thought this was the most confusing part for most listeners the last time. But let me just go through again the whole screening program to say, how does this screening program for Down syndrome work in real practice? Whenever we are screening women, of course, we should be aware that the screening performance is affected by racial origin. So that means the race has to be mentioned whenever you are screening, the weight of the woman, the smoking history, the method of conception, and of course the machine and the reagents used for the analysis of the biochemical samples. And the combined test, which is the most commonest test done in our region, in most parts of Europe and probably America, but most countries are now moving to fetal self-readiness tests. So this test will include the proteins, which is pregnancy-associated plasma protein A, which is PAPA, and the free beta-HCG on top of the nuchal translucency and the maternal age. And it should be done between 11 weeks to 13 weeks and 6 days. And we interpret, in our setup, we interpret 1 in 100 as the low and high risk. But laboratories now report what is called an intermediate risk, which is normally between 1 in 100 and 1 in 500, so that we decide which women to offer fetal self-readiness tests. Then, of course, the additional markers can also be added, which I've already told you. The nasal bone, ductus venosus, Doppler airwave, and the trachea regurgitation can be added. And to put them all together, so this is the combined test, the simple form of the combined test without the additional markers. So in other words, we are saying we include the maternal age, then we include the nuchal translucency, then we include the PAPA and the beta-HCG. One thing to understand with the nuchal translucency is that the nuchal translucency is compared with the CRL. As you can see, this is the nomogram, the distribution of the nuchal translucency after many thousands of cases that were done by Fetal Medicine Foundation. When they plotted the nuchal translucency of normal babies, this was sort of the distribution of how nuchal translucency distributed against crown rumplets. So this therefore means that the nuchal translucency nomogram increases with the CRL. It therefore follows that for a baby with 85 millimeters of crown rump length, a nuchal translucency of about 2.5 may actually be within the 95th centile as compared to a baby with 45 millimeters, where a nuchal translucency of 2.5 is above the 95th centile. This therefore means that you cannot give an arbitrary value and tell a woman that your nuchal translucency is above 2, is 2.8, so it is normal because it is less than 3. It is not correct. You have to plot the nuchal translucency on the crown rump length nomogram for you to know whether the nuchal translucency is within normal range or not. Most modern machines will plot this for you on the nomogram. However, you also have to realize that the 99th centile, of the nuchal translucency is about 3.5, but some papers will report it at 3 millimeters. What is the 99th centile? The 99th centile is that value whereby we say if the measurement we have done, irrespective of the crown rump length, it will be abnormal if it is above 3.5 millimeters. So that is the 99th centile. So I do agree, if you say a value above 3.5 millimeters is abnormal, I do agree to that. But you cannot say a value of above 2.5 millimeters is abnormal arbitrary without comparing it to the CRL. Then when it comes to the biochemical markers, when you look at the graph of the biochemical markers, we can see that for euploid fetuses, the multiples of median is 1. What do we mean by multiples of median? We are saying if we look at babies who are normal and we compare them to babies with Down syndrome, when we divide the the number of times that the measurement of babies with Down syndrome goes into the normal values of the normal population. That is what you call the multiples of median. To say how many times does the value we have obtained from the nuchal translucency for the patient who are testing go into the population median. So the deviation of papier for babies with Down syndrome is more marked when you do the papier when the baby is around 11 weeks compared to when you do it when the baby is towards 13 weeks. So that means papier, which is the other biochemical markers, performs way much better when it is done at 11 weeks compared to when it is done at 13 weeks. However, for beta HCG, it is opposite. So this therefore means when you are screening for Down syndrome, we need to strike for a balance where we do the screening around 12 weeks so that we may benefit from the performance of these two markers. The a priori risk. So whenever a pregnant woman walks into your room, when you ask the pregnant woman the age, just based on the age, the woman will have a risk for having a baby with Down syndrome. And these are the risks as shown there. And the risk changes with the gestational age because some of the babies with chromosome abnormalities die intrauterine or they are miscarried. As a result, the risk changes with gestational age. So this therefore means the a priori risk is not the one that we have to use to tell the woman that your risk is 1 in 70 because you are 40. If we do that, we'll be stuck in the 1970s, whereby they were screening 5% of the pregnancies because most women were getting pregnant, 5% of the pregnant women were getting pregnant after the age of 35, and they were only picking 30% of cases with Down syndrome. Although we know that the demography in developing countries have changed, so that 20% of pregnancies are happening after the age of 35, and they are now picking 50% of the cases of the Down syndrome in women above the age of 35. So if you do use the maternal age alone as your basis for screening, you are going to be missing babies with Down syndrome. And you may apply an invasive test unnecessarily. Then what should we use? This is to show you how the other abnormalities are performed, that is trisomy 18 and 13. But I'll just jump this because it's self-explanatory. The same way I've said it before, I'll just jump this and go to this. I've already explained it, and this one I've explained it. But before I go there, let me just illustrate some of the wrong measurements of NT. This is the wrong measurement of NT because the baby is flexed at the neck. And this is a wrong measurement because the baby is extended at the neck. So you overestimate NT, you underestimate NT. This is wrong because the image is not well zoomed. The image should be zoomed to just show the thorax and the head. This is wrong again because it is oblique. We are seeing the zygoma bone. We don't measure the nuchal translucency on an oblique image. I'll just skip this part. I just want to go to, sorry, right. Just a second. I want to go back to my slide here to explain a little bit further on them. So the message with this slide is to say, do not use the maternal age alone. You have to combine it, maternal age, nuchal translucency, and either the biochemical markers and the additional ultrasound scan markers. This I've already explained how it behaves, that the nuchal translucent behaves with the CRL, and also to explain that nuchal translucency performs better between 11 to 12 weeks than it does at 13 weeks in screening for Down syndrome. So the best time to do this screening is either between 11 to 12 weeks, because it performs better, the test, because you can easily distinguish these babies if you measure at 11 to 12 weeks than if you measure at 13 to 14 weeks there. This has been explained well, and this one. To just show you the distribution of babies with Down syndrome, that babies with Down syndrome are more likely to measure abnormal However, there will still be babies with Down syndrome who will have a normal nuchal translucency. This is the reason why we are saying you cannot tell a woman that your baby is no Down syndrome because the nuchal translucency is normal, because they could have abnormal biochemical markers, because babies with Down syndrome can also measure normal. These graphs are explaining the same picture, but what we are saying is that if the nuchal is abnormal, the likelihood ratio of having Down syndrome increases. Then to do the nuchal translucency, we should always know that the Fetal Medicine Foundation offers training globally and certifies people who do nuchal translucency. If you want to do nuchal translucency in the right way, subject your work to audit by Fetal Medicine Foundation, and you can be certified and be given a certificate that you are doing it properly, because there are consequences of doing nuchal translucency if you are not properly trained and certified. And it is all on the website, and people who are certified to do nuchal translucency are also found on the Fetal Medicine Foundation website for each country. So I want to encourage all performers of ultrasound scan here that please seek certification with the Fetal Medicine Foundation. As the Fetal Medicine Unit in Zimbabwe, we offer training on how to do nuchal translucency properly so that you can be certified. This is just to show you how the quality assurance work. You can do quality assurance on your own by checking how your nuchal translucencies are distributed. This is the normal distribution you see there. And this is when you are underestimating the nuchal translucency. You see that if you do your 100 nuchal translucency and you plot them on the graph, they will all fall below most of them will be distributed below the normal limit there. Then if you are overestimating, this is how your figures will be distributed. This is a soft audit you can also do on your own. Then the PAPI and the beta-HCG, I've already explained these hormones, how they work in terms of the Down syndrome. And we also have to know that they increase, for PAPI, it increases the gestational age. For beta-HCG, it drops the gestational age. But for babies with Down syndrome, PAPI decreases. For babies with Down syndrome, and it is also decreased in the following condition. That includes Edwards, Patau, triploidy, fetal growth restriction, preeclampsia, and preterm birth. Then as for the beta-HCG, it actually peaks around 12 weeks and drops towards pregnancy. But in babies with Down syndrome, it increases so that it reaches two multiples of median. But it is reduced in babies Edwards and Patau syndrome, and also in babies fetal growth restriction and preeclampsia. This is our local experience. We subjected our results to audit, where we submitted the results of our patients on the FMF website, and we were assessed and we passed the audit. And this was our detection rate using nuchal translucence alone and also biochemical markers. We are not doing that bad in terms of our performance. Then in terms of our own experience, in terms of whether women are being screened, we did an audit of the patients who were coming to us in Fetal Medicine Unit in second trimester, and we noted that most practitioners are actually not offering screening for Down syndrome alone. Probably this is reflected in most parts of this region. 53% of the women would tell us that they were never offered by their practitioner, and only 18% were offered combined tests. The other 9% were offered NIPT, and 16% of the women declined any form of test. This is still a very common problem in our region. And of course, we did it during the lockdown period. So some couldn't do it because the lockdown had locked down our laboratory. Currently in our country, we send our sample to South Africa. So they were locked down. The NIPT, I've already described it. It's a fetal cell-free DNA test, which uses these three methods to analyze the fetal cells inside the mother's blood. There is some fragments of the baby's DNA in the mother's blood, which is extracted through these chemical processes, and it is analyzed to estimate the risk. This I'll leave it for another day because it's a very big topic. Then in terms of screening, I want you again to know that the Fetal Medicine Foundation offers license to people who have passed the audit and also the certification. You will be given a license that allows you to calculate the risk for Down syndrome of your patients using any of these parameters. So this software is available at the FMF website to people who have been certified the FMF that they can do nuchal translucency and you can calculate your own risk. To just show you a result interpretation for one of our patients there. So this is just to show you that this is the background risk. This is after adjusting the risk, after putting in all the markers, and this is what we are getting. The software allows us to calculate the risk for preeclampsia, which is the talk for tomorrow, where we screen for preeclampsia as well in first trimester, but I will not dwell in this. But this is for Down syndrome, Edwards, and Patau. So this therefore means that you can calculate for the risk for Down syndrome using these parameters, and also you can include the biochemistry. Once the lab is done, the biochemistry, you can calculate your own risk using the biochemical markers from the lab. I'm just rushing because my time is up. We delay starting a little bit. Then I want to discuss a subject which is a little bit gray, probably in most area. It's called second trimester risk recalculation. What is this risk recalculation? So we are saying a woman who has done a risk in first trimester and they've done a combined test and they've been told that their baby's risk of Down syndrome is 1 in 16,517. But when this woman came for the second trimester anomaly scan, we noted that the nasal bone was absent or hypoplastic. So we are going to take a 1 day, and this formula is an Excel formula. So it's going to recalculate the risk of Down syndrome to see if the woman falls into the high risk category or not. If the woman is still in the low risk category, we reassure the woman that, look, it's highly unlikely that your baby will have Down syndrome and you don't need to do anything to this woman. However, if we noted that on top of the nasal bone, there's also increase in knuckle fold. This will change. How do we come up with this combined likelihood ratio? So what we do is we calculate all the positives here, including these negative ones which are not there. Then we come up with this likelihood ratio. So you can see for this patient, this will change a risk to high risk. The same applies here. If all these markers are, the risk will change, and also here the risk will change. And at the end of the day, the woman will fall into high risk category and to offer a combined test. We offer a diagnostic test, sorry. Then in terms of result handling, if we do the combined test or the fetal self-readiness test and the result is low risk, we just reassure the woman and do nothing. But if the risk is high, there are 3 options. The woman can choose to do nothing as long as she has understood the risk. Then the fetal self-readiness test can also be offered instead of an invasive test. If the risk is high, then we offer the invasive test, chorionic villi assembly for before 15 weeks, and amniocentesis for after. Then this is our recommendation that all women should be offered screening for aneuploidy, and preferably the combined test. And ultrasound scan should always be done, even if a woman is offered self-readiness test. The self-readiness test is not going to tell you that there's anencephaly, it's not going to tell you that there's holoprosencephaly, neither is it going to tell you that there's omphalocele. As a result, the ultrasound scan should always be done, even if you are doing fetal self-readiness tests. Then I think we are done. Thanks to this wonderful team. This was in Alicante with Professor Aneuploidy in Spain last year. With the wonderful team who work with us in fetal medicine in the fetal medicine units. And yeah, I want you to know that Professor Aneuploidy will be speaking tomorrow at the ZSOJ meeting, and please get in touch and connect and hear him speak on preeclampsia screening in developing nations. Thank you so much. Bye-bye. Thank you, Dr. Lagadakalo. It's done.